The Australian Safe Communities Foundation and Safe Communities Foundation New Zealand are proud to present this webinar titled Injury Data and Your Safe Community. And it's quite fortuitous that we're looking at injury data today, as 2013 is the International Year of Statistics, a worldwide event that is supported by many thousands of organisations. In this webinar, you'll hear from 4 presenters who will present different perspectives on how injury data relates to improving the safety of your community. First of all, we will have Dr. Simon Gianotti from the Accident Compensation Corporation in New Zealand. He will be followed by Tessa Sturley from the Waimakere District Council in New Zealand. I hope I pronounced that correctly, Tessa. Tessa will be followed by the Associate Professor Leslie Bell from the Victorian Injury Surveillance Unit in Melbourne. And our final presenter will be Maria Plakakakis from the City of Melbourne here in Australia. Remember that if you have a question, please fill in the little question section on your control panel. I now have great pleasure in introducing Dr. Simon Gianotti. So I'm going to hand over to him now to begin our webinar today. So welcome, Simon. Just bear with me for one moment and I'll bring up his panel and we'll hand over to him. It's over to you, Simon. Thank you.
Standing in for Dr. John Wren, who's the Principal Advisor at ACC. I am the Principal Advisor in Injury Prevention, so we work quite closely together. John's apologised for not being able to deliver it today. He's had a non-injury procedure on Monday and then needs a couple of days to recover from that. That's the first bit of housekeeping. The second bit of housekeeping is I'm based in Wellington and we've had a few earthquakes, particularly last week, and the reason I'm telling you that is if at any stage I drop off or drop underneath the desk, you know what's happening, and I'll be ending the webinar shortly after that to head outside if it's all clear. What I'm about to talk to you today is John's research on the impact of health comorbidities on the injury experience, and it's using the ACC data. For those non-New Zealanders, ACC processes about 1.7 million claims a year. In most of the states in Australia, you'll have a workplace injury insurance scheme and a road injury insurance scheme. Well, in New Zealand, ACC does both those, but it also covers non-work, non-road injury insurance as well. So we'll look after home sport, the whole 9 yards. So that gives us a unique experience, and it also gives us a unique data set. And we also cover everybody, so it's the no fault, and we'll be drawing on our data for this. Well, what I'm going to talk to you about, or what John's set up to talk to you about, is we're going to be looking at some costs of comorbidities to an insurance scheme, which is ours. But before that, we'll be taking an overview of some of the literature about what's available and what's out there. And a lot of this literature is cited at the back, and there's also some information on wellness programs that John wanted to share with you, which can lead to reducing some comorbidities. So if you have the question we're trying to ask is, if you have a health issue or comorbidity, do you need more, is it going to cost us more? Are you going to take more time off work? Is the treatment going to be more complicated? Does this cost more to the health system and the insurance scheme? And so that's where a lot of John's work has come in to be able to do. And the answer, he says, in one word, is yes, it certainly does cost. And looking at what some of the comorbidities are, these are the ones that John looked at, and it's a range of health events. And like I said, we're looking at whether the presence of these impact on an insurance injury scheme such as ours. And he said to tell you again, it's unequivocally yes. So why should IP practitioners be concerned with this? John believes that it's not really well understood or well known at it, but it's certainly, in his opinion, in his research, it increases, or a comorbidity, a health one, increases the risk of injury. It does lead to higher treatment and rehabilitation costs. It increases time off work due to complications of treatment and rehabilitation. But also when people do turn up to work, they can become distracted as a result of that comorbidity, and that can lead to poorer work performances. The other thing about comorbidities is people who have a particular comorbidity can come together as a group. You might see a diabetes support group or one of the other ones in there, and that gives us as IP practitioners almost a unique cluster or a group that we can work with for an intervention to put into place, or at least make them aware of the risk. Some of the health literature around and there's some good documentation from WHO. They've investigated and come up with the conclusion that injured people are different from non-injury people in respect to comorbidities. They also say that patients with higher numbers of comorbidities utilize services more than patients with lower comorbidities. And to that, an insurance thing means that, or in the hospital scheme as well, means more treatment and rehabilitation. And the example John wanted me to share was people with diabetes. He suggested that people with diabetes have less feeling on their extremities, such as their fingers and their toes. So things like cuts and burns tend to be more severe because they don't know that they're cutting themselves, because the sensitivity isn't like somebody without diabetes. So when they do cut themselves, and they do know that they've cut themselves or burnt themselves, it's actually more severe as well. So that leads to longer treatment, longer costs, and so forth. Some of the health literature also shows about comorbidities, and this is one, and it's cited further down the back, and it compares the comorbidities down on the left-hand column here with the injured versus non-injured, and whether the person went to it was a hospital admission or physician, and it's done in claims per 1,000 years. And basically the 9.3 here is it means that people are 9 times more likely to have a hospital admission compared to a non-injured person with that comorbidity. If they're going to see a physician, it's 3.5. So you can quickly get an idea that people with comorbidities actually have a higher risk of injury when you glance your eyes down the scheme. Some of the other health literature, and he was particularly struck by this when it came out because it's uncommon for such a statement to be made, to say there's pretty much a causal link or an etiological link between mental health conditions and injury, particularly in relation to risk-taking, behaviours, alcohol use. And that's very rare. Sometimes we'll say there's an association or there appears to be an association, but to have something come out and say so strongly, particularly by Harrison, is somewhat of note. Turning to the workers' compensation literature, again, higher injury risks, higher medical treatments and costs, workers' compensation, all these types of things are consistently being associated with a lifestyle risk. Here in New Zealand, we've been developing something with truck drivers called Fit for the Road. And we noticed, looking at our claims data, that the unfit truck drivers, or the obese truck drivers, seem to be the ones that were having more road injuries. And when a truck driver has a road injury, it's usually quite large and usually quite a few vehicles as well. So we've actually put an intervention in place and helped them reduce their obesity levels and stress and some of the other things around that. And those truck drivers that were rather large gentlemen are now not as large. They're still a little bit large, but the injury risk has come down, and so has the crashes. So we do know that the two are inherently linked. There's considerable confidence that the excess risk from comorbidities around 25 to 30% of medical costs, and shortly I'll be taking you through some of ours and what our costs actually are. But the biggest costs, though, are extra treatment, utilisation of medical services, and that's associated with the comorbidity. But I understand it's also a very topical debate. So turning back to what our research has got, we know from looking at our data where we've been able to look at the comorbidities, we're able to see that people with a health comorbidity, when they're making a claim to us, there's 28% more claims. There's 346% higher lump sum payments. And the lump sum payments in this particular area, as an example, is usually for amputation, and that's where that of losing an arm or a leg, which we cover to a certain extent, and that's that diabetes example that I was using before. We also know there's 59% higher medical treatment costs and 39% more weekly compensation costs, which ACC covers a large proportion of that. So when you start putting some of those costs around, you can actually see that the percentages are quite high. And so overall, 59% more total ACC cash costs across the category. And cash costs in this definition means the amount that we would pay out in one financial year. When you wrap all that together, we currently estimate, or John currently estimates, 10.7 of the annual cash costs, so the amount we'd pay out in one particular year, is attributed to the presence of comorbidities in New Zealand. Now, that's about 276 million New Zealand dollars, that's in last year, and so that's probably about $3.50 in Australian dollars, given the exchange rate at the moment. But for us, that's a reasonable sort of problem and presents a reasonably large problem in terms of identifying a group that presents that much of a cash cost to us. John's also put in some further information from different people he's done, and he's also put in some additional slides around health and workplace and what makes an effective program, and there's some more stuff all the way through there. So now if I escape out, and Alan, can you take me back as presenter? Is that how it works?
Really interesting presentation around comorbidity, and I look forward to reading a wee bit more about that. My name is Tessa Sturley, and I lead the community team at the Waimakariri District Council. We're based about 30 minutes north of Christchurch and have a population of just over 50,000. Our district incorporates 4 small to medium-sized towns and a number of farming and lifestyle areas. Like Christchurch, part of our district suffered some fairly severe impact of the Canterbury earthquakes, and a big part of our business currently is welcoming newcomers into the district, supporting those affected by the earthquakes to transition back into life as normal, and working with some of the growth in the district. The community team incorporates community development, growing the community, crime prevention, youth development, unintentional injury, and road safety. I'd just like to thank the Safe Community Foundation for inviting me to share some of our experiences of how we've utilised data, particularly in reducing injury in the Waimakariri district. First of all, I'd just like to say a word about what we want from our data, how we can make data work for us. So obviously it guides us in setting our priorities, but it's also useful in program design, so making use of formative data to help to inform how we put together projects that meet their target and the right audience. Data helps us to deliver the best possible outcomes for our community, but also can create some good outcomes for us. So if we utilise data properly and use the right data, it really helps us in acquiring funding. We can paint a better picture. It can help us with promotion to increase the reach of our interventions, so we can publish data in local media and get people's attention more easily, and then to start to create a safety culture. Also, it's useful in reporting to community funders and our governance groups. So for us, data presents a number of challenges, and particularly if you look at the data around unintentional injury, there are some conflicting numbers depending on who's taken the data, where it comes from. Sometimes there are gaps, delays in getting good data, for instance from the coronial service, and also with respect to deciding what we're going to do, there can be conflict between huge figures for one injury prevention issue on a national level, and that might not be the case locally. So it's really important to us to find good ways of finding out what the truth is and getting the best out of that. So I'd just like to spend a quick minute talking about a model that we used in setting our priorities, and this is a Canadian model, the PortColeman Model, and I picked it up from the Safe Community Conference in 2009, I think, or 2008 in Christchurch. This model looks at the quantitative data from a variety of sources and also gets stakeholders around the table to look at some of the qualitative data. So how do we know? The numbers tell us one thing, but are there other things influencing whether we should prioritise a certain injury issue? I'm just going to skim quickly through this. So we brought together a number of stakeholders, and they were everyone from people just generally in the community through to key stakeholders from the likes of ACC and road safety. We got them to examine the data, rank it, and then ask themselves a series of questions that help to put together some qualitative information around those priorities. So this was the data that we got. As you can see, we got hospitalisations, we got death data, both from Otago University, ACC figures, emergency department discharges, and data around length of stay in hospital and St John's Ambulance. And if you look at the various sources, and you'll note that the time periods are different, and we would acknowledge too that there may be some double ups there. But what we decided to do was to be a bit forgiving and put the imperfection to one side and just plot all the data onto one chart so that we can have a look at trends. So we then gave each issue a ranking for each data source. So decided whether it was priority 1 or priority 10, and then we added them up so that the lowest overall ranking score determined the highest priority in terms of injury for our district. So that was pretty easy, but obviously numbers aren't always enough. So our usual data doesn't tell us how many people are having to be rescued by Surf Lifesaving or Coast Guard, whether someone's already doing a really good job of addressing a particular high-level injury for us. So we wanted to put some context with the numbers so that we could paint a more detailed picture. And that helped us to, as I've said before, ensure that we were developing programs that met their mark and making the best use of the money that was granted to us for injury prevention. So we provided our stakeholders with some additional information that we'd sought from the various experts or partners that we were working with. And they considered this alongside a variety of questions. So they asked questions like whether the issue was being addressed by another group or agency, whether certain sectors of the community were overrepresented in relation to those injury issues, whether the community knew or didn't know how to keep themselves safe, were they receptive, was the political environment right, and you can see those questions on your screen, and they ranked those in order of strongly agreeing or strongly disagreeing. And that allowed us to prioritise each injury issue qualitatively as well. So what we then did was combine those two scores to get an overall priority ranking. And that was quite important because something that scored high in terms of data might have scored quite low in terms of the qualitative ranking. So if the fire service were doing a fantastic job of fire safety prevention, they had a huge multifaceted campaign, it might have scored quite low on a qualitative ranking. And then the overall ranking would have determined that perhaps we were better just supporting the marvellous job that they were doing rather than going all out and developing an intervention. So that worked relatively well for us in terms of setting priorities for unintentional injury. However, there are difficulties in getting good data to inform other areas, and these include family violence and suicide, and also not just setting priorities, but also in informing strategies to address those priorities. So it's useful for us to think about what other data sources apart from the mainstream, the usual suspects that we might consider. And a couple of things that have been really useful to us are making use of our networks. So for instance, we have a really close relationship with local police. We get a certain amount of anecdotal information from them. We've also been quite lucky to work quite closely with a suicide prevention coordinator from Partnership Health in Canterbury, and he's part of a pilot to get better information, better data around local suicide and more timely data. So that relationship's been really useful to us. Also, we're considering at the moment whether we can facilitate the creation of better systems around data. So for instance, an issue for our local police was that the POL 400 or the family violence incidents recording process was that they were getting the data, but no one was doing anything with it. No one was collating it. They weren't able to manipulate it. So we're just wondering whether we can advocate for getting better use out of that data, and then we can use it ourselves. Pulling in the experts is a really useful thing to do as well. So quite often people like your TLA's policy and strategy department or student statisticians, and I'm wondering whether that's a typo, but those people can have a better insight into the type of data that you should be getting, where to get it from, and they can do a bit of the donkey work for you, particularly in terms of things like developing surveys and telling you how to run a good focus group so that you are getting good information. So making use of those experts is really useful. Surveys, focus groups, community forum, all aimed at getting better evidence to inform and guide and develop our projects and programs. So just quickly going to cover a little bit about the use of data in formative and impact evaluation. So when we're designing an intervention or a project or program around unintentional injury, we've got the data that informs that it's a priority. But if we're going to meet our mark, we need to know a little bit more about our target audience, about what we're measuring. So are we measuring behaviour change, or are we measuring how the reach of the information that we're getting out there? How are we going to gather that information, how we're going to attract our target audience, and how we're going to promote our findings. So it's really important to get as many stakeholders together as possible to help inform that process. So as I've said, data is a really vital component of planning. However, sometimes the data just relates to some very basic demographic information. We want causal information, behavioural information, and other demographic information. So the process that we go through with our stakeholders is to brainstorm who's going to give you more evidence. So it might be that we don't have some people around the table, to gather the anecdotal evidence and to identify the target audience and who they might think they are. I'm just going to give you an example of how we put that into practice to develop some good data. So we have a DIY Falls campaign, because men in the 40 to 50 year demographic were identified as being at the greatest risk of injury in the Waimakariri district. So we decided to do something about that. We got a number of stakeholders around the table, including a large DIY outfit, a hire service, Department of Labour, ACC, and some various others, and we decided to put together a formative evaluation that would help us to get some good information about whether what they were saying was the issue. So we put surveys in all of the local DIY stores, the rural outlets, and the hire centres, asking people what they did when they used a ladder. So did they put a block under it? Did they stand on the top 2 steps? Was their ladder really dodgy? And with the information that came back from those surveys, we put out a full 2-page spread in the local paper, and we detailed some of our findings, provided some good information about how to stay safe, and set up a dodgy ladder amnesty because it appeared that people were using unsafe equipment. So we were able to put that formative gathering of data to good use. We were also able to ensure that our resources and our campaign met the target audience, which was the wives of these women in the 40 to 50 year age group, who had expressed at some displays that they were really concerned about their husbands and they didn't know what to do about it. So we put the wife and the children into the picture so that we might be able to, you know, generate a sense of guilt or responsibility towards safe practice. We also thought they weren't very keen on being particularly safe, that it wasn't seen as a manly thing, so we came up with the slogan, just to be on the safe side. You know, why not give it a crack? So they were resources that we came up with out of that. We did something similar with a paracetamol campaign where we gauged knowledge and use of paracetamol before we launched into some public education and provision of resources. So, so we had that formative data, and we were then able to, as I said, form the campaign so that it would meet its target audience, but we needed to also find out whether it had met its mark. So we reran the surveys 12 months down the track and that guided us into ongoing planning. So that was really good process evaluation. So for instance, if we found out that one behaviour had improved but another one hadn't particularly, we could modify the campaign around that and relook at it further down the track. We made a point of recording any anecdotal feedback from the public or stakeholders along the way, and that was twofold. Again, it was process evaluation to guide the future direction, but also it was really good in terms of being able to promote the findings through local media. And in doing that, we were able to reinforce the messages, increase the reach, and hopefully contribute to a culture change in the community. And that's just an example of some of the media stuff. I just want to speak really quickly about evaluating displays and using data for those, and as a means of gathering data. So quite often we'll set up a display, and how do we know if we're making a difference? We stand there, we've got some great resources, it all looks lovely, but we want to make them work for us. We don't want to end up with our evaluation just saying that we've handed out 500 flyers. And we also want to be able to ensure that that is information that will work for us. So this is a display that we did at a local home show, and we linked it to a competition. So we asked people to write down 2 things that had stood out for them, 2 statistics that had surprised them, and 1 thing that they might be able to take away and change their behaviour in relation to. And sorry.
Tessa, we have about one more minute to go. Thank you.
I've got one more slide. Okay, thank you. So I'll just pause for a minute. So this was really useful for us, and that not only did we have that information that we could promote about how our program had made a difference, but we could also follow up with people as to whether they had committed to that behaviour change. So my final slide is, once you've got good data, make sure you report it into a way that tells the story well. Use graphs, because they can really make a difference in terms of making people sit up and listen. And importantly, how you present your data can have the potential to increase buy-in and also make you more attractive to funders. And the final slide is just our annual report card that we put out with our results every year. Thank you.
Thank you, Tessa. What a fantastic report. Yeah, you're obviously doing some really, really great things in your community. We're now going to hand over to Associate Professor Leslie Day, and Leslie's going to talk to us a little bit about what's happening over in Victoria. So bear with me for one moment.
Participate in this webinar. I'm the Director of the Victorian Injury Surveillance Unit at University, and so what I'm going to speak about this morning is this gives one example of a data source that's available to support injury prevention at both the state and local level in Victoria. So VISU is a state-based injury surveillance unit, as I said, based here at Monash. And sorry, I'm just having trouble seeing my screen with all the other bits and pieces. Okay, so we hold data on injury-related deaths and capture all of those. We have data on hospital admissions, all public and private hospital admissions in Victoria, and also emergency department presentations from all hospitals that have a 24-hour emergency department, which covers about 80% of ED presentations in Victoria. So as you can imagine, these are quite large data sets, and they do cover fairly long periods of time now, and they're all coded with standard coding systems, which enables us to do comparisons with data from elsewhere. We've made some enhancements to the data systems over time, so we've added extra variables in that increase the amount of information or the types of information we're able to provide. And so it's developed into a relatively mature injury surveillance system. It's funded by the Victorian Department of Health, and we have outcomes and key performance indicators that are agreed in consultation with the department at the start of each triennium. But it's important to note that while we're funded by the department, we are external to the department, and so we're able to provide specialist expertise to the government. We have freedom for advocacy, and it increases the public access to the data, because while the health department actually holds much of this data, the access of the public to it through the health department is zero. So the aim of our unit is to provide data and information to reduce injuries in the Victorian community. And as you might expect then, our functions are to collate and analyse the data, to measure and characterise injury, to monitor trends over time, and also to disseminate the data and information to support prevention, research and evaluation. We have a number of different ways that we get our data out so that it can be used. We publish an e-bulletin every year, which goes up on our website when we get the next available year of death and unintentional injury data. We analyse that and produce a summary that goes up onto our web page, and that shows frequencies, rates, trends, the different causes of injury, the types of locations they occur in, what people are doing at the time, and the sorts of injuries that they have. We also produce a publication called Hazard, which some people who are participating in the seminar may have heard of. We produce 2 editions of Hazard each year, and we examine selected injury issues in depth in each of those publications using our data sets, but also summarising the latest literature on the topic. So even for people outside of Victoria, these editions of Hazards can sometimes be useful reference documents because of the summary of the literature available on the topic. We select the issues that we cover in Hazard on the basis of the frequency and severity of injuries as they occur in our data systems, what the preventability might be, and also to some extent on the level of government and community interest in a particular injury topic. We also try and highlight emerging issues, so if we see new things appearing in the data, we do highlight those in Hazard so that people can be aware of them. And then we disseminate that out to just over 1,000 subscribers. Plus we also often have an additional dissemination list of key stakeholders for specific editions depending on what the topic is. We also have an information request service where people, the members of the public or organisations or government can request data from us, and we service about 200 of those requests each year. There's a web-based system for lodging requests, so people can just go onto our web and tell us what they'd like. And mostly we can process those requests within 5 days, or certainly within the time period that people need the data in. And for simple requests that only take a couple of hours of our time, there's no fee. For the more complex requests, we charge an hourly fee. And this graph just gives you an idea of the range of our clients. This is for 2011-2012, but the pattern's been pretty stable over a number of years now. So our largest client group is government, and that includes federal, state and local government, followed by the media, and you can see the other sectors there. We have a number of injury prevention organisations that also contact us for data as well, like KidSafe, for example. Other ways that we get our data out there, we do short reports from time to time on certain topics. We publish in the peer-reviewed literature so that other researchers can see what's happening with the data. We go to conferences. We often give presentations at meetings and seminars like this one, as well as making press releases and giving interviews with the media. We also do a fair bit of work at developing partnerships with different agencies around the state, so that this can then help to expand the use of our data for prevention purposes. So, for example, divisions and branches obviously within the Department of Health, but also other government departments, local government, as well as non-government organisations. We have a particular relationship with the Australian Consumer and Competition Commission, who are responsible for product safety in Victoria. We've worked, for example, with the Victorian Sports Injury Prevention Task Force by giving them local government sports injury profiles, which has guided their strategy development. And we also support safe community development here in Victoria by providing geographic profiles on injury to guide their prioritisation and also to monitor trends. And these next slides just give you a couple of examples of the way our data has been used by local government, which is probably the primary agency through which safe community action occurs in Victoria. So we've provided profiles for municipal public health plans, which are required by the state government. All local governments must have a municipal public health plan. And so that's obviously helps with targeting and monitoring and planning service provision. Some local councils have requested information to support risk assessments around various activities. We've provided background and data for funding submissions that local governments have been making, and also details on specific injury types following a recent injury incident that had a high profile in a particular area, and that was being used to increase community awareness of injury risks. Our data has also been used to inform local safety advertising or promotion campaigns. It's been used to resolve differences of opinion among local groups regarding the safety of specific activities, so it's helped to resolve their priority setting when there's been a difference about which things should be given priority. It's also been used to guide brochures and material for parents and fathers in particular. We've noticed an increasing trend in local governments putting out information directed at fathers, and also to inform action on specific injury issues. And there's a few specific examples listed there. Just turning now to how our data is used for trend monitoring and evaluation. This shows you just gives you an example of one of the types of graphs that we publish routinely in our e-bulletin, so that people can see what's happening over time with injury in Victoria. And as you can see here, the admission rate is going, or the frequency at least, of admissions is certainly going up over time. And we do also include rates in that publication as well. And we've provided injury data and trends on indicators for a range of different monitoring activities here in Victoria, including, for example, the Safe Start program, which was a local level initiative to prevent injuries amongst young children. And we've also been able to have some impact at a broader level on particular injury outcomes, and this gives you one example which relates to trampoline injuries. This is an area that VISU has been monitoring for quite some time. We've identified the size and the scope of the problem, shown where most of them happen and what most of the injuries are. We've supplied the data to a review which went on to recommend the development of an Australian standard. And advocacy from ourselves as well as from other bodies then resulted in the initiation of the development of a standard, and we were on that standards committee, and that standard is currently being revised and updated, and again the revision and the update of the standard has to some measure been guided by the different trends that we're now starting to see with trampoline related injuries. It's not all rosy in the garden though. There are some challenges for us, and I've given some examples of some of those here. So data quality is always a challenge because these are administrative data sets rather than being a purpose-specific data set, and so they don't always get the attention that they should at the point of collection. The coding classification systems that the data are coded with can sometimes limit our extraction flexibility, so there are some specific issues, for example, that communities might be interested in, but which we can't identify in our databases. Our hospital data is episode-based, not person-based, and the narrative, we get narratives with some of the data that we collect, which actually provides quite a lot of useful information if they're completed with sufficient detail, and again we're reliant on busy clinical staff to provide that information. We have some challenges in displaying the data in formats that are readily interpretable and that people at community level can then use directly in their campaigns, and we think we're getting better at that. We've certainly have experimented with different ways of presenting the data. Timeliness is an issue, as I think Tessa alluded to, and that's probably telling me that time is up. So you can see that there's some other challenges that we also have to face. So I'll close there and hand back to Alan so that he can move on to the next presenter.
Thank you, Leslie. What a sort of wonderful array. Thank you.
Hi everyone, and thank you Leslie, thank you the other speakers. Leslie, I must say that we do use the Visu data and it's extremely helpful, so thank you for all that fantastic work you do for us. I've decided, after having read through what people are doing, to sort of mix it up a little bit for you. So I'm going to start with, hang on. So, as with everybody else, we agree that we're not actually short of tools to gather evidence and build our knowledge. And I'm going to use a term, growing our knowledge, because we want to build knowledge equity. So it's really important for us to actually look at the breadth of tools that we have available to us to give us that broader picture. So we do go to research, which is commissioned or provided by academic institutions, organisations, government bodies and experts. We also use video ethnography, and I'm going to show you an example of that today. So we try to capture images and stories on video. We do a lot of consultation. It's one of the key cornerstones of how we work. So we run summits, we target particular groups, we speak to individuals, and we do lots of intercept type of surveying out on the street. We evaluate programs, policies, strategies, initiatives. We often go about making requests for data from organisations like Visu, VicPol, Crime Stats, Ambulance Data, Turning Point, wanting to understand drugs and alcohol. And if it is extensive, we do have to pay for it. So Leslie alluded to, you know, if there's small requests, we probably don't have to pay, but if they're a bigger project, then we do have to pay for that information. So we try to factor that into our budgets as well. We also bring in consultants to develop reports for us, especially our perceptions of safety. And looking at drugs and alcohol and the impacts in our community. We have very specific meetings with Victoria Police and the service sector, community safety, and so we run audits as well around community safety, and we look at ICEPT audits as well, which is interventions with environmental design. We also look at social media, so YouTube, hits on Facebook. How many times does a hit lead to somebody opening up a page and then going into the metadata of that page? We collect that type of information. We also look at our CCTV programs. We look at crime and antisocial behaviour. We look at amenity concerns. We have a mobile vehicle which travels around to places where we don't have CCTV cameras, and so we collect information around what's happening in parks, what else is going on in amenity, unmonitored areas of the city. We have advisory committees, we do lots of surveying. We have our key stakeholders where we discuss intelligence and operations. And we also have lists, heaps of lists of key stakeholders across the organisation, and we consider that an extremely useful data source because it's the content in that and the people that we connect with, which actually provides us lots of information in relation to other evidence that we want to look at and other data sources. And again, we have data visualisation, so we have tables, graphs, and all sorts of visualisation, which again I will talk to you about. So why the need for good evidence base? Really, it's about influencing good decision making. So refining how our resources are managed and where we invest our capital, and that includes money, people, and the knowledge. Why do we care about the level of scrutiny we place on our data or our research? So we want good information to understand the nature of the current state in order to influence the future state. A lot of people don't talk about the future when they look at good evidence, but we want to know what's happening now so that we can actually change what's going on in the future. So for the City of Melbourne, the future plays a role in our thinking. we're anticipating improved states in the future. So in the bill form, in what's happening socially, if we're wanting to improve legislation, so we can have better outcomes for community in the future, better community outcomes. We want healthier communities, active, participating communities, community that feels that they're part of something exciting, and that they have a sense of belonging, that indicate they are proud of where they live, work, study, and recreate. So we look at all the different community groups. So our visitors to the city, we try very much to try to factor in how we might engage with them to find out how we're travelling in all sorts of areas. We also look at, we want our communities to be better able to manage their own affairs. Why do we do all this? We want to alleviate the costs of negative consequences on our resources and the city resources. And I must add, you know, we don't want negative media hype, which isn't uncalled for. So I titled this specific presentation, Evidence-Based Planning and Understanding Our Community and Their Needs. And I wanted to talk to you about this model that we work under. Our CEO, Dr. Kathy Alexander, has brought into across every branch a methodology called Lean. So it's very much around Toyota's way of thinking. So it came from an assembly line of how to put cars together and how to improve efficiencies. And we have taken that now, and it's just the way we actually do business. And it's very much centred on getting good information to save waste, to improve efficiencies, and to really understand what's going on in our community. So if you have a look at how we move around, at the very heart of what we do is we think about our community, our customers, and the values that we want to embed. We also want to manage expectations, and we want to build consensus about what we do. So we're very specific about how we define problems, and then we work really hard to acquire and build the evidence base and to grow the evidence. So we'll consult, we'll engage, we'll talk to our key stakeholders, we'll run our summits. This is where we use as many tools as we can that are relevant, of course, and we work collaboratively to consider what we want to find out. Then when you go to this area here, we evaluate the evidence. So we scrutinise, we debate about it, we hypothesise further, we discuss it, we share it, and we ask the question, is it compelling? What's missing? If it is compelling and it makes sense, and we've had a few people look at it, and we've reached approval to use it, then we accept it. And we're able then to consider our decisions. We're able to then look at how we might use those findings. So we go to the next part of the cycle, which is very much about applying the findings and moving into that future state and looking at creating change. While we're doing that, we're also considering our evaluation mechanisms, our frameworks, and considering our planning and implementation. And I agree with Tessa, going up to assessing outcomes, very much part of this is about building on the original evidence base. So again, growing our evidence, sustaining the evidence base effort, cataloguing the evidence. So across council, we did a really big audit of what sort of research we're collecting, who's collecting it, and where are we putting it so that across council, people are able to share it, understand it, and look at the protocols for accessing it if they're working on a piece of work or a project or a policy where they might find it useful. So we want to measure the outcomes, we want to share the success, and we also want to record what we've been doing and what the processes are. So this is one way, this is a model of looking at evidence-based planning. If you want to find out more, I've included a bit of a website down the bottom. And I must add that everything we do at the City of Melbourne being a capital city, we're always under the political, strategic and media spotlight. So we're very conscious of how we behave and what sort of evidence we're putting out there and what we talk to. So let's look at an example. Taxi availability late at night. We had a problem our customers were telling us it's difficult to get a taxi after 2:30 a.m. in the central business district on the weekends. We didn't have good understanding of taxi flow, availability of taxis late at night, and where they were going. And why was this important to us? It impacts on our reputation as a livable city, affects perceptions of safety, and increases complaints because people don't actually have safe transport home late at night. So what data do we have available? We had recorded taxi trips and destinations collected at our Safe City taxi ranks. These were paper-based data entry. We discussed the information with the taxi industry and we clarified the usefulness of it. There were significant challenges with what we had recorded. It was incomplete, it wasn't accurate, it was anecdotal, and we were considering relying more closely on the GPS data that the taxi industry held. But what we discovered is that their technology wasn't up to date at that point in time to go ahead and actually do this type of work and do this visualisation. What we all agreed on was to do an anecdotal exercise to see what the data would tell us. And we invited Flink Labs, and I've got their website there if you want to find out more about them, to take some of the anecdotal data around destination and plot it on a graph to tell us where the taxis were going. So we did a pilot based on what we had to provide us with anecdotal evidence that we could use to further engage key stakeholders. And we consulted with members, Victoria Police and licensees and transport providers to come up with this visualisation that you can see in the grey. I hope you can see it clearly. It's a little bit small. I actually tried to get the link to actually play it so that you could see it, but it wasn't working, so I'm very sorry about that. But what you can see is the bigger dots on that grey page tell you where the taxis are going, and those, if this was in motion, you'd actually see those dots growing. So you'd actually see taxis are leaving the city and are going out to those spots. So Port Phillip, you could see a time motion, and for 8 o'clock at night you could see how many taxis were going out to Port Phillip. You could see how many taxis were going to St Kilda. You could see how many taxis were going out to Frankston. And if you were to put the cursor over the dots, it would actually tell you the number of taxis that had left the city on a particular day at a particular time and had travelled to that spot. So it was really interesting, really useful information. And what we did was we showed this visualisation to our taxi providers, and they are now right on board with wanting to look at how their new technology can provide us with better information to do a much broader visualisation of this and sort of understand a little bit more about taxi flow. If you'd like to have a look at how New York did it, there's a little link down the bottom because New York actually tried to do this as well. We also had another issue. A popular supermarket chain had applied for a packaged liquor licence within the Swanston Street precinct, and basically the City of Melbourne did not want this application for a packaged liquor outlet to be granted. Why? We thought it would be conducive to alcohol use and misuse, and that there would be further consequences and harm to the community in that area. So what we did, we collected lots of data, and this isn't the actual representation. I thought I'd do a mock-up so I thought it would be really important for you guys to have a look at the sorts of information that we were collecting. So the yellow dots are significant transport hubs. The red dots indicate where we have disadvantaged people using the area, and we do have disadvantaged people like Indigenous people. We have food vans, we have youth food trucks in those areas which are highlighted in red. We also have a number of fast food outlets, which is the green little marker, and then we have lots of packaged liquor outlets in the area. They're in blue. We also have known hotspots for antisocial behaviour and crime. So we tried to prove that basically this area was an area of disadvantage where we needed to exercise caution. And the evidence that we collected was very descriptive. There were the Victorian crime stats, we had ambulance data, we had pedestrian injury data in that area. We had also put together a package of key stakeholders and their thoughts on what goes on with Indigenous people and young people in that area. Salvation Army provided a letter of support, and we were able to present that information to the panel. And we objected quite formally to the panel, and our argument was formulated based on risk assessment of the issues and risk for community. The panel felt that the evidence that we had put together was compelling and didn't grant the application. Now, we continue to grow the evidence in this particular area, so we've used this material again, and we have successfully, in other cases, where a current packaging outlet wanted to extend its trading hours for 1 hour on a Saturday night, this too didn't go ahead. So we were able to say, using the evidence, that even 1 hour in that particular area could be harmful to community, and that it was our right as a council to protect community and to mitigate that risk. Okay. We also, I agree with Leslie that statistics are certainly not enough. So City of Melbourne invests a lot of time in visualisations and talking to community and gathering that information. So we did a research project looking at dusk till dawn. What was our problem? Despite large volume media stories providing viewpoints on the violence that occurs in Melbourne, we didn't have a lot of research examining the experience of the community's thoughts of Melbourne at night. Council then didn't have the whole picture. It was difficult to make decisions about policy to do with the late night environment in Melbourne if we didn't really understand what was going on late at night and we hadn't invested in good information. So what we did was we did a blend of statistical and qualitative data research, and this is the sort of information that we received back. So the community was telling us that Melbourne has a buzz, that they do feel safe, that generally nearly 95% of the candidates that were surveyed felt that perceptions of safety were pretty good for Melbourne. We had, in Melbourne there's so many streets and so many shops and so many people and always something going on, always some lights and noises and activity going on, so we really love it. So you can see that different groups were saying really great things about our city late at night. And we were also able to look at pedestrian flow. So yellow tells us the areas where there's high numbers of people in the daytime, and red was we were able to see that we were very similar spots at night, people using those same areas. Incidentally, our injury data also told us that City of Melbourne in those particular areas also has high incidence of pedestrian accidents in there as well. So, we're looking at that quite closely through our road safety plans. We were also able to look at restaurants, where's the proliferation of restaurants in the city, and we were able to see at 9 o'clock at night how many bars, taverns were open, at 12 o'clock at night how many are still remaining open, and then which ones are the 24-hour package liquor outlets and late night venues, which we were quite surprised there weren't that many because of the licensing changes. Things have changed in our environment, which is fantastic to see too. And we have seen a big turnaround in crime and antisocial behaviour because key stakeholders have been working hard to manage the demands of community safety within the city. What I also would like to do, and I know Alan, time's running out and I'm nearly finished.
Got about 1 minute to go.
You a DVD. Okay, so if I show you this DVD, oops. So this is a visual representation. We wanted to understand amenity There was a lot of waste in the Swanson Street area, a lot of paper waste. We just wanted to understand what was going on, so we decided to videotape a time lapse. So police were telling us there was lots of paper out on the street, that the fast food outlets weren't taking responsibility for the waste that was accumulating. So we decided to do some time lapse videotaping of a couple of areas in the city, and this is what came back. The next phase of this was to actually go out there and take photos as well. And we're now having in place a fast food project where we're going to engage with all the fast food operators to come into the city and to come into our offices and just sit down and have a bit of a chat and put our responsibilities in making sure the city looks tidy and kept any time of day or night. Okay. So we were collecting that type of information through the Dust Till Dawn project as well. And then I think Leslie really alluded to a lot of this, so I won't go into any details, but we do have challenges with the evidence, accuracy, specificity, the completeness and the coherence, very similar to what Leslie was saying. And finishing off with, and when is enough proof enough? So at some point you've got to make a decision to apply the information, and as long as it is compelling and that you have sort of approval processes about how you've made decisions and how you've used the data, then we go ahead and we develop our plans and we implement new initiatives. Thank you, everybody.
Thank you, Maria. What a sort of wonderful presentation. There's some great things happening there in Melbourne. I know there was a chance for people to put in their questions, and there were just a couple. I'm going to send those to the presenters and ask them to respond, and we'll send those out via email. So on behalf of everyone that's participated today, can I thank Simon, Tessa, Leslie and Maria for their wonderful presentations. And I hope that we're all a little bit wiser and understand a little bit more about how injury data can certainly make our community safer. So on behalf of the organisers, thank you for everyone for attending. I apologise for the little sound problems at the beginning, but I'm quite sure that you at the other end would have sort of got some really good information. So thank you, everyone. And we'll see you at the next webinar, which will be on the 18th of September, looking at child safety and evidence-based strategies. So thank you, everyone.